Great day to everyone. Once again, this is my new recording for Pharmacology 2 for clinical therapeutics. Yeah. This is Dr. Benji Cabrera. Uh, we'll try to tackle and clear up clinical therapeutics on antimicrobial. So for the clinical therapeutics of antimicrobial, we have a lengthy lecture for today. So I have divided my lecture into three parts. So I'll just be starting with this part one with the principle of the antimicrobial therapy. Then part two, I'll be tackling on the beta-lactams until the miscellaneous antimicrobial agents. And part three from antimicrobacterial drugs and to the drugs for COVID. Okay, so let us now start. Okay, to start with, what is empiric antimicrobial therapy? It is the action or the principle that we as physicians will take before the specific pathogen has been identified. So this is the one that we decide, the drugs that we will be deciding to use even before we are able to specifically identify a certain organism that may have caused the disease. So it's the empiric therapy. This is based on the presumption of an infection that requires immediate treatment. Before the initiation, we have to consider the clinical diagnosis of the microbial infection. Then, before the initiation, we must obtain specimens for laboratory analysis, and we must have our microbiologic diagnosis. Then, hopefully, we have a fast result, especially in our culture, in gram stains, or in either bacterial culture or viral culture. Then we can have our microbiology diagnosis. We proceed if we have the specific. So we decide later on if we will continue with our empiric, or now we will base our medicine towards the result of our culture studies. In either way, we as always should be selecting the optimal drugs for a particular infectious disease condition. So here is a very beautiful table regarding the drugs of first choice and even the alternative ones in any organism that we might be considering. It will be based upon the history, the presentation, the chief complaints of the patient. So a very good base on microbiology and history and PE is necessary to make a very good decision regarding the empiric therapy that you'll be giving to your patient. Like, if you'll be considering enterococcus infection, we can give as our first line would be our ampicillin with or without gentamicin, if ever. Okay, we'll be considering Neisseria gonorrhea, or your patient came in with severe dysuria, as if they really have painful urination, and with the history of sexual exposure, especially for males, we can now at least empirically give IM ceftriaxone or oral cefixime. So if ever these medicines are not available, or they are the patient is hypersensitive to it, then we can give the alternative, which is your spictinomycin and your azithromycin. If ever, again, with your history, you have patients with syphilis, okay, with high risk of syphilis, whatever you may be seeing, primary, secondary, or even tertiary type of syphilis, then you can give as your uh, first line would be your penicillin. Then you may either give your doxycycline or ceftriaxone, or even azithromycin. And so as with your other organisms, like in here, okay, you might be considering Shigella infection, basing on uh, maybe your patient presented with bloody stools and fever, cramped abdominal pain, and with a high risk for food contamination, then you can give your empirically fluoroquinolone or either azitro, thimetocloprid, sulfamethoxazole, or your cotrimoxazole, ampicillin, and even ceftriaxone. So this will all be based, so your empiric therapy can be based on a very good investigation on your uh, history and physical examination. So for the clinical therapeutics of antimicrobial, so we have a lengthy lecture for today. So I have divided my lecture into three parts. So I'll just be starting with this part one with the principle of the antimicrobial therapy. Then part two, I'll be tackling on the beta-lactams until the miscellaneous antimicrobial agents. And part 3 from antimicrobacterial drugs and to the drugs for COVID. Okay, so let us now start. Then we now talk on the principles of antimicrobial therapy. Okay, we have your susceptibility testing. Then we can have your drug concentrations in the blood for susceptibility testing. So before we initiate any treatment, at least we should be having samples for susceptibility testing for culture and sensitivity. Then there are two most common methods. You can give your this diffusion, which is your Kirby-Bauer and broth dilution. And for severe infection by certain bacteria, like your gram-positive cocci or Haemophilus influenza, you can do your direct test for your beta-lactamase if ever that is available for in your locality. Then for drug concentration, always consider those drugs with low therapeutic index like your aminoglycosides and your vancomycin. And uh, always consider again, investigate for if there will be poor clinical response. So you look why your patient is not responding to your expectation, to your expected result once you use your empiric therapy. Then another again, you can have your serum bactericidal titers for infections in which host defenses may contribute meaningfully to cure. This principle, again, as we have to clarify, our medications or our antibiotics is only used, can they either be bactericidal or bacteriostatic. But still, okay, uh, the, the treatment or the cure will be mostly be relying on the host defense, how immunocompetent your host will be or your patient will be. So you can use in cases that you will have an immunocompromised host or patient, then might as well decide as your empiric your management be of the bactericidal drugs, the use of bactericidal drugs. And for serum bactericidal titers, you can do your serial dilution of serum, okay, which are incubated along with the pathogens. Then killing of the dilution of 1:8 is generally considered satisfactory. Then consider also your route of administration. And how would you administer your drugs? Can it be oral or IV, okay, or topical? Okay. Then monitor therapeutic response. Um, of course, when you start your treatment, you should be expecting clinical improvement. First, clinical improvement. So the easiest and the most common clinical improvement, especially with infections, with the presence of fever, especially those patients who have intact immune system or immunocompetent. So they would really mount the reaction for fever in a certain infectious clinical setting. Then you'll have your fever as your main presentation. Then once you start your antibiotics, what you should be expecting should be the lysis of fever or the decrease in the intensity of your fever. And of course, we should always be very conscious on the proper treatment and monitoring as to not to as to prevent the development of resistance or even super infections if ever in cases that we are not we do not fully cover everything, especially in the immunocompromised patient. So the duration of drug therapy is required will be dependent on the pathogen. Okay? The longer the courses of therapy are required for infection caused by fungi or or the most common example would be a mycobacterial infection. So we all know that the standard treatment now for mycobacterial infection would be at least 6 months with 2 months of intensive and 4 months of maintenance phase. Or consider the duration of therapy basing on the site of infection. Like you would be using a longer uh, treatment period for endocarditis and osteomyelitis. Okay? And of course, the duration of treatment will still be dependent in the immunocompetence of our patients. And then we consider the clinical failure of antimicrobial. So for the clinical therapeutics of antimicrobial, so we have a lengthy lecture for today. So I have divided my lecture into 3 parts. So I'll just be starting with this part 1 with the principle of the antimicrobial therapy. Then part 2, I'll be tackling on the beta-lactams until the miscellaneous antimicrobial agents. And part 3 from antimicrobacterial drugs and to the drugs for COVID. Okay, so let us now start therapy. Then the factors influencing antimicrobial drug use, uh, we consider bactericidal versus bacteriostatic actions. Examples of your bacteriostatic meaning they prevent further multiplication by hampering with the would be the capacity of the bacteria to multiply. You can especially if they mess up with the ribosomes or in the protein metabolism of a certain bacteria, like your clindamycin, your macrolides, your sulfonamides, and your tetracyclines. And for your bactericidal, so these are usually are drugs that will hit or destroy the bacterial cell wall. Okay? They destroy them, making the bacteria susceptible to the environment later on, like your aminoglycoside, the beta-lactams, okay, they are fluoroquinolones, your metronidazole, most of your mycobacterial agents, your streptogamins, your vancomycin, okay, and your bactericidal agents are the preferred, okay, drugs for the treatment of your endocarditis and your meningitis. Okay. Then the factors influencing antimicrobial drug use will be considering the concentration-dependent killing. In examples will be your aminoglycosides, your fluoroquinolones. They maximize peak blood levels, will increase in the rate and extent of bacterial effects. So the higher the level, the 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 higher the bactericidal effect. But of course, you have to take note of the how high can the body tolerate. Okay, so your concentration dependent killing will be responsible for the clinical effectiveness of high dose once daily dosing administration of your glycogen. Another one daily dosing would be your azithromycin for your macrolides. Then your time-dependent killing, so how long will you be exposing the organism? These are very important in the drugs like your beta-lactams and your vancomycin. So the killing action is also, aside from the time of exposure, will be the killing action is independent of the drug concentration. So it doesn't care if how high the concentration, as long as it is on the effective concentration. The time that the organism will be exposed will be the one that is mostly significant. So in time-dependent killing continues only while blood levels are maintained above the minimal bactericidal concentration. Then the post-antibiotic effect, always consider the post-antibiotic effect, like the inhibition of the bacterial growth that continues after antibiotic. Blood concentrations have fallen to low level. So what is the significance of this one? So as clinicians later on, uh, of course, we would try to have a fast and uh, treatment, okay, of our cases, but unfortunately, we also have to be very, um, we should mind the post-antibiotic effect. Okay, that's why in this era, we should always be sure of what we are treating or dealing with, and you should be very mindful of the significance of the post-antibiotic effect. Like if you will be using in the era of the significant stuff of the gut microbiota. So the principle is once you use antibiotics, okay, there are studies that says that the antibiotics may have at least an post-antibiotic effect to the gut microbiota for at least a year. So please be very careful in using your antibiotics. Use your antibiotics with great care and with uh, real indications, not just because you are afraid or the patient is demanding for it, especially in the clinics. Some of our patients may be will just be going to your clinic just to ask for antibiotics for viral infections. So please explain to them that you should be using antibiotics judiciously because uh, these antibiotics may have an effect on the gut microbiota, which later on will have a significant um, effect on the total overall health your patient. Then the persistence of an target site and has susceptible bacterial defense mechanism and contribute to effective and once daily administration, okay, of aminoglycos and efficacy of your fluoroquinolones. Then in using your antibiotics, so we should be mindful of the drug elimination mechanism. How do we take care of the drug? So how do we remove them from our system? So in cases of anuria, this wherein your creatinine clearance is less than 5 ml per m per minute, the elimination half-life of renal excreted drugs are markedly increased. Okay? There's major reductions in dosage. Okay, so you do not like these antibiotics, which are mostly studied in humans that has an intact, okay, elimination system. So you do not like these antibiotics to be staying so long as to cause now, instead of the benefit may be now be causing problems to your patient. So in cases of your anuria, okay, you should be looking, okay, considering your drugs that will be excreted through the renal route. But there are drugs that will require no change in dosage in cases of renal failure, like your erythromycin, your clindamycin, your chloramphenicol, rifampicin, and ketoconazole. Okay, and for those drugs that really need to not to be given in cases of your renal impairment, these are your cidofovir, your nalidixic acid, okay, your long-acting sulfonamides, and your tetracyclines. The dosage adjusted may be needed in patients with hepatic impairment also, like your chloramphenicol, your clindamycin, your erythromycin, and your metronidazole. So in patients that will be requiring, in those with renal failure that will be requiring dialysis, so the process itself will markedly decrease the plasma levels of many antimicrobials like your okay. There are also drugs that are not removed from the blood by hemodialysis. So these are the drugs that are not affected, like your amphotericin B, your cefonicid, your cefoperazone, your ceftriaxone, your erythromycin, your nafcillin, and tetracyclines, and your vancomycins. So these are the drugs that are not affected or removed by hemodialysis, and most of the drugs will be affected by hemodialysis. And in pregnancy and the neonate, so we should always be careful in using our antibiotics, like high dose and prolonged use of your aminoglycoside, like your gentamicin, your amikacins, can bring about neurologic damage. Okay? Or like your streptomycin can have ototoxicity, okay, neurologic damage, okay? And your tetracycline can bring about tooth enamel dysplasia and inhibition of bone growth. Your sulfonamides, okay, will displace, okay, bilirubin from the serum albumin, thus increasing now the levels of your serum bilirubin, and poses increased risk for your patient to have kernicterus. Your chloramphenicol can bring about gray baby syndrome, and your fluoroquinolone, if used in children less than 18 years old, can have an effect on the growing cartilage. For drug interactions, there are some combination of drugs that might that can give rise to an additive side effects like enhanced nephrotoxicity or ototoxicity when your aminoglycoside is combined with either your loop diuretics, vancomycin, or cisplatin. Or there will be interaction with sulfonamides that are based on competition for your plasma protein binding, like your excessive hypoglycemias with sulfonylurias when it is given with sulfonamides, or increased hypoprothrombinemia with warfarin if it is used with sulfonamides. And there will be disulfiram reactions to ethanol, like the use of your metronidazole, okay, your cotrimoxazole or trimethoprim sulfamethoxazole, and several cephalosporins. The erythromycin can inhibit hepatic metabolism of clozapine, your lidocaine, your loratadine, your phenytoin, quinidine, your sildenafil, your theophylline, and your warfarin. To continue for the drug interactions, you should always be conscious that your ketoconazole, which is an antifungal drug, inhibits the metabolism of your caffeine, okay, carbamazepine, your cyclosporine, and your HMG-CoA, or your 3-hydroxy-3-methylbutyryl coenzyme A reductase, or those of statins. Okay, so these are lipid-lowering medications used in the primary and secondary prevention of your coronary artery disease. Okay, so be careful in using that. And your methadone, your oral contraceptives, your phenytoins, your sildenafil, that is used for your erectile dysfunction, your verapamil, your zolpidem, okay. Other azole antifungals are weaker inhibitors of the drug metabolism. Rifampin, okay, is an inducer of hepatic drug metabolizing enzyme and decreases the effect of, okay, the following: your digoxin, your ketoconazole, oral contraceptive, propanolol, quinidine, the antiretroviral drugs, and the warfarin. So these drug interactions must always be considered in emergency situation wherein our aim is to suppress or most likely pathogens. In the management and our aim to delay resistance, like in the treatment of tuberculosis, or in the presence of mixed infections, like your peritoneal infections, wherein there will be a combination of your anaerobes, your coliform, your gram-positive, and your gram-negative, and your skin infections, which can have a mixed bacterial, fungal, and even viral pathogens. Then to achieve synergistic effects, fourth, your penicillin with gentamicin is used for the treatment of enterococcal endocarditis. Your extended spectrum penicillin plus aminoglycoside, that will have a synergistic effect, especially in the treatment of your Pseudomonas aeruginosa. Your amphotericin B and your flucytosine can be used for the treatment of your cryptococcal meningitis. And also there are drugs that is used for sequential blockade, like inhibition of 2 or more steps in the metabolic pathway, as exhibited by your cotrimoxazole or your trimethoprim sulfamethoxazole. It inhibits different steps in the formation of the tetrahydrofolic acid, or it may act as blockade of drug inactivating enzymes, like the addition of your clavulanic acid to your or sulbactam and tazobactam. Okay, these drugs, when added like clavulanic with amoxicillin, producing your co-amoxiclav. Okay, sulbactam with ampicillin, your ampisulbactam, and your tazobactam, your piperacillin and tazobactam. Addition of these drug inactivating enzymes will inhibit the penicillinase and used with the penicillin sensitive beta-lactam drugs. So there are also drugs that are used to enhance drug uptake, like the increased permeability to aminoglycoside after exposure of certain bacteria to beta-lactams. And the last principle would be the antimicrobial chemoprophylaxis. And for this principle, prophylaxis should always be directed towards a specific pathogen, and no resistance should develop during the period of drug use. We use it for a limited duration, and therapeutic doses should be used, so not underdose or overdose, and only in situation of documented drug efficacy. So still, these are all based on anti cultures. Okay, so in patients with the acquired immune deficiency syndrome, prophylactic measures are directed towards the prevention of pneumocystis jirovecii, pneumonia or PCP, and toxoplasmosis. Then for post-surgical infections, limited to procedures that are associated with 5% uh, of untreated cases under optimal condition, then we can give prophylaxis like your first-gen cephalosporin, which is your cevasolin, which is the most often prophylactic drug of choice, or in cases that will be using, will be operating on cases with high risk for anaerobic bacteria, like your abdominal surgery, then we can use cefoxitin or cefotetan. So that ends the first part of the three-part lecture series on antimicrobial therapeutics. So I'll be seeing you on the next slide. So for the clinical therapeutics of antimicrobial, so we have a lengthy lecture for today. So I have divided my lecture into three parts. So I'll just be starting with this part one with the principle of the antimicrobial therapy. Then part two, I'll be tackling on the beta-lactams until the miscellaneous antimicrobial agents. And part three from antimicrobacterial drugs and to the drugs for COVID. Okay, so let us now start.